With Robinhood, not only can you trade individual stocks and ETFs, you can also seamlessly buy and sell crypto at low costs. Trade all in one place. Get started now on Robinhood. Trading crypto involves significant risk. Crypto trading is offered through an account with Robinhood Crypto LLC. Robinhood Crypto is licensed to engage in virtual currency business activity by the New York State Department of Financial Services. Crypto held through Robinhood Crypto is not FDIC insured or SIPC protected. Investing involves risk, including loss of principal. Securities trading is offered through an account with Robinhood Financial LLC, member SIPC, a registered broker-dealer.
Hey everybody, welcome back to my podcast, Anatomy and Physiology Bit by Bit. This is your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, just outside of Philadelphia. In today's episode, we're going to finish up the respiratory system. We're going to talk a lot about the respiratory function. We're also going to talk a little bit about some laws of physics and chemistry that are really important to how the lungs function. We have laws that are governing the pressure and volume of gases. We have laws that are governing the movement of gases across a membrane. We also have some effects that are going to determine when oxygen is released from hemoglobin versus when oxygen is loaded onto hemoglobin. So we've got a lot to discuss in terms of the physical laws that are governing what the lungs do. That's really important. So we will finish all that up today. But first, I do have a guest today. And that guest is a dental hygienist in suburban Chicago. And she is also my sister. She has been a dental hygienist for quite some years now, and she has quite a history of clinical practice, plus also working as a dental hygienist outside of clinical practice and what kind of opportunities might be available for people in the dental hygiene field. So without further ado, I want you to please join me and listen to my conversation with my sister, Christina Byrne, who is a registered dental hygienist in the state of Illinois. I think that you'll get a lot out of this. If anyone is interested in a career in dental hygiene, this is something you want to listen to, because we talked about all the requirements to get into a program, what the program requires so that you can actually be a practicing dental hygienist. And I think it's really going to help out anyone who is at all interested in what that field might be like. It's only about 13 or 14 minutes or so take the time to listen to my conversation with my sister, Christina Byrne, and on the other side, we'll finish up talking about the respiratory system. All right, Christina Byrne out in suburban Chicago, thank you so much for joining me.
It's my pleasure.
So, Chris, even though everyone already knows that you're my sister, I'm going to ask you to share with us your background and why did you choose dental hygiene for a career?
All right. So I did work in a dental office after high school, and I really enjoyed it. I think it's a really great career. You can not just fix people's teeth, but you can change people's lives. And I always was drawn to stuff with immediate gratification. So you can fix a tooth that's broken. So I was looking to go back to school, and I had started to think about going to nursing school. And so while I was in my prerequisites, one of my instructors had asked for my background. And so she found out that I had been in dentistry before and asked me if I would consider hygiene. So I thought about it and I was like, you know what? That's probably a good idea. I have a lot of experience in dentistry already, and I thought I could have a little bit of a leg up when I got to hygiene school. So I switched my major from nursing to dental hygiene.
Nice. And how long did it take academically? How long is the program to be a dental hygienist?
Well, once you have all your prerequisites done, it is 2 full years. So it's 5 semesters. And then the prereqs, depending on what you need, it might take longer, because if you started out and you didn't have all those science classes, then you are going to have to take a bunch of those to get you ready for the actual program.
What prereqs are you talking about?
So I took Anatomy and Physiology 1 and 2, Microbiology 1 and 2. We needed organic chemistry, psychology, sociology, nutrition, speech class, math class if necessary. So there were quite a few prerequisites. It was interesting to me as a non-traditional student to be back in the classroom again. I took it a lot more seriously than I did the first time because it was leading to what my career choice was going to be, and also I was paying for it. So
That's a pretty robust program. That's a lot of coursework.
yeah, and that's just the prereqs.
Right, right. Is it the same in every state, or does it differ from state to state in what you need to be a hygienist?
So I think it differs from state to state and maybe even region to region and perhaps even school to school, depending on whatever the curriculum requirements are for that particular school. Obviously, once you're in the dental hygiene program, it's pretty standardized for that state because each state has their own practice act and what they require. So one thing, for example, when I was going through hygiene school, we didn't have a local anesthesia course, which hygienists can deliver local anesthesia, which is what people would commonly call Novocaine. And it wasn't adopted in my state until after I graduated. So I had to go back to school and take that as a separate course.
Okay. And are you licensed by the state?
Yes, you're licensed
Okay.
by the state and the region. So each region has their own boards and then usually encompasses, I don't know, 7 to 10 or 12 states would accept that regional board, but each state then has their own licensing program as well.
Okay. So if you wanted to move to a different state, the region license isn't enough. You'd have to get also a license in that separate state.
Correct, correct. So I did move from Ohio to Illinois. I was part of the Northeast Regional Board, which Illinois is. So I didn't have to retake my boards, which was nice, but I did have to submit and send a whole bunch of information to the state of Illinois. And then they gave me my license here.
Okay. So living in suburban Philadelphia, I would object to Illinois being part of the Northeast, but that's okay. I think we
Right.
could live with
I
it.
agree. I agree. It's hard. You know, one of the things that hygienists are pushing for is to have a national exam and a national board so that we can transport between states. The nurses are able to do it and we're just not able to. So it's probably a lot because the states do have different requirements. There are some states that are a lot more restrictive in what hygienists can do and what the practice can do. So, for example, in North Carolina, hygienists can't work unless the doctor is physically in the office. I believe they're one of the very last ones to ever do that. But most other states have something called general supervision, which means that the hygienist can work when the doctor's not in the office.
Okay. So what do dental hygienists do essentially? Like what would be a day in the life of a dental hygienist in clinical practice?
Right. So we obviously we see patients, we remove calculus and plaque and
Wait, what is that? Like I took calculus. What does that mean?
calculus is what people would call tartar.
Okay.
It's just a calculus deposit. We can remove it from the entire surface of the tooth, whether it's above the gum line or below the gum line. And that's kind of the literal sense of what we do, but there's a bunch of stuff that we do. We communicate with the patients, we listen to the patients. I heard your last guest talk about open-ended questions and using active listening and things like that. And it's so important because just like with those medical assistants, the hygienist is often the first point of contact for the dentist. And so we have to gather a ton of information to understand what's happening with that patient. Going back to the curriculum, we take oral pathology, we take pharmacology, we take head and neck anatomy, we take tooth anatomy and morphology and things like that so that we can make a really good assessment and diagnosis for the doctor before they come into the room.
Okay. So they're doing a lot of stuff.
Oh yeah,
Um, and what about x-rays? Who's taking those?
we are. Yep,
Okay.
radiology another that's another course we have to take and competency that we have to pass before we would graduate. It's part of our boards. We have to present several full mouth series of radiographs. We do all of it.
Okay. It's a pretty busy day for a
Mhm.
dental hygienist. What would you say is the earning potential?
It varies state to state and again, region to region. So there are some states where a hygienist might make $35 to $40 an hour. And then there's other states where the hygienist could make upwards of $80 to $90 an hour. And obviously that's going to be more on the coasts, and more of the, center and south of the country is probably going to be a little bit lower. But it follows with cost of living as well.
That's pretty good.
Yeah. Oh yeah. It's a great career. It
It
really
is
is.
a really good career for someone interested in the health professions.
Mhm.
So are there career paths other than clinical practice for hygienists?
Yes, and I'm living that right now. So when I was ready to leave clinical hygiene, I took a job with Johnson and Johnson. So I was a sales rep with them. That was not really my jam. So what I decided to do was leave that role, and I started working at a dental practice coaching company. So similar to a consultant. And what we do is we go into the practices and we help them to put systems in place. We help them with their culture. We help the doctor in the leadership aspect of the practice. They don't get any dental practice training when they're in dental school, and they often don't know how to lead people and run a business. And so we help them out in that respect. That's what I do now. But there's a lot of other avenues there. There's education, so they can go into teaching either in the classroom or in the clinic. They can help students come up. There's public health. There's a new-ish area of dental hygiene called myofunctional therapy, and that's really interesting. It's focused around airway and breathing, and it starts from tiny babies, just finding out, do they have the ability to retrain the muscles in the mouth and the muscles of mastication. Oftentimes they come in because they're not nursing well, and we find out that they are tongue tied and they need to have just a minor little surgery to release that frenum. And then they train the muscles, and they end up being great, having full airway function. It's an up and coming field within dental hygiene.
That's pretty cool. I had never even heard of that.
Yeah, it is very, very cool.
So I got two more questions. One, what's the job market like for dental hygienists?
So right now it's very good, I would say. There is a shortage. A lot of hygienists left the field during COVID. It was super, super stressful. We already were trained in universal precautions, and so it was, we knew what we had to do, but it just became really hard for a lot of hygienists. So a lot of them left the field. But I would say right now is a good time if you are looking to get into hygiene. Definitely do it. It's a great career. There should be lots of opportunities for you. I would say too, the majority of hygienists right now are probably in the back half of their careers. So there will be this bigger opportunity in the next 10 to 15 years, I would say.
That's good to know, people who are interested in the career.
Hmm.
All right, I lied. I got two questions. I got two more still. I thought
Okay.
of another one. So here's one that everybody wants to know, the truth. How
Okay.
many times should I be flossing?
Once a day.
Once a day? Okay. All right,
Yep.
I can
At
do that.
least
I
once
can
a
do once
day.
a day. All right, good. And then my last
And
question. Oh, go ahead.
oh, I was going to say, and we know if you only floss the day before your visit, we can tell.
You
So don't
can
tell us
tell.
that you floss every day and you've only like really quick went in and flossed that morning.
You just ruined my day. I thought I had it. I thought I had that one over on them.
Nope.
All right, so here's my next question, and we'll leave it with this. What is your favorite thing that you've ever done as a hygienist?
Favorite thing I've ever done as a hygienist. There's so many things, and as I said at the very beginning, it's all about changing lives. It's not necessarily just cleaning teeth. Having people trust you and make changes that are positive to their lives. We often see patients and they don't have a medical doctor. So we're detecting and seeing, do they have high blood pressure? Do they possibly have any blockages in their carotids? Because we're taking that panoramic x-ray and we can see that on there. Oral cancer is another thing that we do, that we screen for, and being able to avoid potential serious consequences when a patient is not going to a regular physician. They come to us twice a year, and we can find that for them. One of the favorite things that happened one time, this was when I was in Ohio and I worked in an office, and this doctor was amazing. We had a great relationship. And I had a patient come in and she sat in my chair and she just started bawling. And she had some personal things happening in her life. And I just shut my door and I never even picked up a scaler. Like, we just sat the whole hour and just chatted. And it was, it was a great thing. And I never even picked up my instruments.
Wow, that's amazing. I love my hygienist. I think she's great. That was great. I think we learned a ton about dental hygiene, and I really thank you for joining me and giving all this information to the listeners. I think we probably have a lot of people who already are thinking dental hygiene, and that's why they're taking anatomy and physiology.
Yeah,
That's usually a handful of my students every semester. So
that's
I
great.
really appreciate that. Thank you so much
Yeah,
for sharing all of that information.
of course. It's my pleasure.
All right. Thanks again. Talk to you soon.
Okay.
Okay, once again, thank you, Chris, for joining me and letting all of the listeners know about the career of dental hygiene. I think this is a good one. I usually have a handful of students every year who are interested in dental hygiene, taking anatomy and physiology, so I'm guessing that some of you out there might also be interested in this great field. Once again, I will include any pertinent links in the show notes so that you can look at those at your leisure. In the meantime, let's get back to the respiratory system.
You buy a pair of socks, that's 2 socks. You buy a pair of Bombas socks, that's 4 socks. Because one purchased is one donated. Socks are the #1 most requested clothing item in homeless shelters. So when you buy a pair of super comfortable Bombas socks, you're also donating a pair. Bombas customers have powered over 150 million donations. So Bombas would like to thank you 150 million times. But we only have like 30 seconds. Go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
I want to start by talking about some of the different laws that are governing the respiratory system. Some of the things that are important to understand so that you can understand how the respiratory system functions. So these are laws of physics or chemistry, or they're just effects that tend to take place with the molecules that we're dealing with the chemical reactions that are required for the respiratory system to function the way it does. So we're going to start off with Boyle's law. Boyle's law states that the pressure of a gas is inversely proportional to its volume, provided the temperature is constant. So if you think about this, it means that when the volume of a container gets smaller, the pressure on the contents of that container becomes greater. So the formula would be P1 times V1 equals P2 times V2, meaning that if your thoracic cavity decreases in size, then the air that exists in your thoracic cavity will be under much more pressure than it was before. Now, during inspiration, we do the opposite. During inspiration, the diaphragm and the intercostal muscles contract, increasing the volume of the thoracic cavity. So as the diaphragm contracts, it flattens out. So the floor of the thoracic cavity bottoms out. We talked about this in the last episode. And that reduces the intrapulmonary pressure so that it's lower than the atmospheric pressure outside your body. Since air moves down its pressure gradient, air will then flow into the lungs from outside. Now, during expiration, we relax the diaphragm and it domes back up. So the floor of the thoracic cavity goes up. That decreases the volume of the thoracic cavity. But also, we have the elastic tissue of the lungs creating a force, increasing the pressure on the air that's inside our lungs, so that the pressure is now greater than atmospheric pressure and the air rushes out. That's Boyle's law that is determining that. Now, another one dealing with pressure is Dalton's law of partial pressures. And we're going to talk about that in a lot of detail a little bit later on in this episode. But in general, it basically means that in a mixture of gases, each gas exerts its own pressure independently of the others. And the total pressure is the sum of all of those pressures for all the gases. So each gas's portion of the pressure is called its partial pressure. So, for example, if a mixture of air has nitrogen, oxygen, hydrogen, water vapor, carbon dioxide, all of those different gases, they all combine to create a total pressure of that air. The percentage of each of those gases is exerting its own piece of that pressure. So we call that the partial pressure. So if the pressure of air is, I'm going to use a round number, but it's not this, but let's use a round number. If the pressure of air in a system is 1,000 millimeters of mercury, and oxygen is 50% of that air, then the partial pressure of oxygen is 500 millimeters of mercury. It is whatever portion of the total mixture oxygen makes up. That's what its partial pressure is. So we'll talk about that in more detail later because partial pressures are really important when it comes to the exchange of gases across a membrane, specifically across the respiratory membrane, and also when we are delivering oxygen to our tissues. So that's called Dalton's law. We also have Henry's law. Henry's law states that the amount of gas dissolved in a liquid is directly proportional to its partial pressure and its solubility in the liquid. So it explains the solubility of oxygen and carbon dioxide in blood plasma. So when we talk about respiration, we're not just going to talk about the movement of gases across the alveolar membrane or respiratory membrane in the lungs so that we can bring in oxygen and get rid of carbon dioxide. We also have to deliver that oxygen to our tissues and take the carbon dioxide from the tissues. So we have to concern ourselves with Henry's law because those gases are going to be dissolved in blood plasma. Oxygen is going to diffuse into the blood from the alveoli because its partial pressure is higher in the alveoli than in the blood. Carbon dioxide will diffuse out of the blood because its partial pressure is higher in the blood than in the alveoli. Another one we are concerned with is the Haldane effect. The Haldane effect says that deoxygenated hemoglobin has a higher affinity for carbon dioxide than oxygenated hemoglobin. It facilitates carbon dioxide transport from tissues to the lungs. And when hemoglobin releases oxygen at the tissues, it can more effectively bind carbon dioxide for removal. So what we want is when the hemoglobin lets go of its oxygen at the tissue so the tissues can take it, now we want that deoxygenated hemoglobin to have a higher affinity for carbon dioxide so that we can get the carbon dioxide out of the tissues, bring it to the lungs, and breathe it out. We also have related to that the Bohr effect, which means that hemoglobin's oxygen binding affinity decreases with a lower pH or higher levels of carbon dioxide. So this is really important because with the Bohr effect, it's going to help us enhance oxygen unloading at the tissues where carbon dioxide levels are high and pH is low. And it's going to promote oxygen loading in the lungs where carbon dioxide levels are low, so pH is higher. So remember, we transport about 70% of our carbon dioxide as carbonic acid, which means that higher levels of carbon dioxide are going to give us more acidic blood plasma. More acidic means lower pH. So the lower the pH, the higher the oxygen binding affinity is with hemoglobin, which means when tissues have been really active and their carbon dioxide levels go up, hemoglobin is going to be more apt to release oxygen, and then the tissues can take it up. And the opposite is also true. And finally, we have Charles' law. Charles' law says that the volume of a gas is directly proportional to its temperature, provided pressure remains constant. So earlier we talked about the pressure and volume of gas being inversely proportional. as long as temperature is constant. Now we can say that the volume of a gas is directly proportional to its temperature, provided that pressure is constant. So basically this means that inspired air is warmer when it enters our lungs, and that slightly increases its volume to help support ventilation. Having said that, let's talk a little bit more about Dalton's law of partial pressure, because this is really important to understanding gas exchange. Let's start by talking about the Earth's atmosphere. The atmosphere is the mixture of gases that surrounds the Earth. We call this mixture of gases air. Since our atmosphere is a closed system, those gases exert a pressure on everything else existing inside our atmosphere. It's not all that different than the pressure exerted by air inside a balloon. You see, air is matter, and no two pieces of matter can occupy the same space. But since molecules and atoms are always moving, air is bumping into everything else in the atmosphere. This constant force is what we call pressure. Since air is a mixture of several gases, each with their own atoms and own molecules banging into things, each one of those gases exerts its own pressure. To figure out how much of the overall pressure one gas is responsible for is pretty simple, because it's just proportional to its percentage of the mixture. And that's what we call partial pressure. For example, atmospheric air consists mostly of nitrogen, oxygen, carbon dioxide, and water vapor, like I mentioned earlier. The amount of water vapor in the air is dependent upon temperature and humidity, but we'll assume it's a nice, clear, mild day. There are other gases, but they're in very, very small amounts, so we're just going to really focus on the main components of air. Oxygen makes up about 20.9% of atmospheric air. If the atmospheric pressure at sea level is 760 millimeters of mercury, all you have to do is calculate 20.9% of 760. And then you have the partial pressure of oxygen. So it's basically PO2, a capital letter P, and then subscript O2 for oxygen. To calculate this, basically all you have to do is move the decimal of the percentage to the left 2 digits. So 20.9% is 20.9 per 100. So really, another way to say that is 0.209. That's the same thing as 20.9%. So if you multiply 760 millimeters of mercury by 0.209, you get 159 millimeters of mercury. Now for respiration, it's not all about oxygen. So we also want to calculate the partial pressure of carbon dioxide. Carbon dioxide is 0.04% of our atmosphere. So that is going to be multiplying 760 millimeters of mercury by 0.0004, right? We move the decimal 2 places to the left. And that is going to give us a reading of 0.3 millimeters of mercury. Much, much smaller number than what we get from oxygen. So now we can use this to understand gas exchange. We're going to apply these partial pressures to what exists in the air we inhale and the blood that is going through our circulatory system. When we talk about gas exchange, we're referring to the movement of oxygen and carbon dioxide into or out of our blood, which takes place across a membrane. This happens in the lungs, at the alveolus, and in the systemic tissues between the capillaries and the interstitial fluid. You see, we use our respiratory and circulatory systems together so we can deliver the oxygen our systemic tissues need to make ATP, and we can pick up the carbon dioxide waste product they produce as a result. What we'll do first is look at the gas exchange between the alveolus and the pulmonary capillaries. The pulmonary capillaries are the microscopic blood vessels coming from the heart to the lungs. They're going to engage in their gas exchange, and then that blood is going to head back to the heart on the left side. The alveolar epithelium has a thin film of watery alveolar fluid lining it. Oxygen and carbon dioxide must be dissolved in this fluid before they can diffuse across the respiratory membrane. And remember, Henry's law states that the amount of gas dissolved in a liquid is directly proportional to its partial pressure and its solubility in that liquid. That respiratory membrane consists of the alveolar epithelium, the pulmonary capillaries epithelium, and the shared basement membrane between those two. Even though the partial pressure of oxygen at sea level is 159 millimeters of mercury, the inhaled alveolar air's partial pressure of oxygen is only 104 millimeters of mercury. And there's two reasons for this. One, the alveolar air is constantly subjected to the unloading of carbon dioxide from the blood. And two, the moist lining of the respiratory tract humidifies the air as it comes in. These two factors decrease the percentage of oxygen in the air that finally reaches the alveolus. For the same reason, the partial pressure of carbon dioxide in the alveolar air is about 40 millimeters of mercury, which is way higher than that of atmospheric air. Remember, atmospheric air was only 0.03 millimeters of mercury. Now we're at 40 when we get into the alveolus. Oxygen-poor blood from the body's systemic tissue makes it to the right side of the heart. Remember that from my circulatory episodes. The right ventricle of the heart pumps that blood into the pulmonary trunk, and it eventually makes its way to the pulmonary capillaries of the lungs. You can review the circulatory system episodes to go through the directional blood flow, the pulmonary blood flow, the systemic blood flow, all of those things, arteries to arterioles, to capillaries, to venules, to veins, assuming you remember all of that, right? Very important. The partial pressure of oxygen in that capillary blood is only 40 millimeters of mercury because much of that oxygen has been delivered to the systemic tissues already. That's why we call it oxygen-poor blood. You might hear people call it deoxygenated blood, but that's not a great term because there's still oxygen in it. Conversely, the partial pressure of carbon dioxide is 46 millimeters of mercury in that oxygen-poor blood. That's because it was loaded into the blood by the systemic tissues. The difference in partial pressures across the respiratory membrane constitutes a gradient, which means it's higher on one side than it is on the other side for each of these. And remember, each gas will move down its own partial pressure gradient, independent of the other gases. So in the alveolus, oxygen moves across the membrane from the alveolar air into the capillary blood until its partial pressure is 104 millimeters of mercury on both sides. The same goes for carbon dioxide. It moves down its gradient until the partial pressure of carbon dioxide is 46 millimeters of mercury on both sides of the membrane. That newly oxygen-rich blood in the pulmonary capillaries continues to flow into the pulmonary venules and pulmonary veins until it returns to the left side of the heart. There, it is pumped back into the systemic circulation because it's now ready to deliver oxygen to the tissues and has plenty of room to pick up carbon dioxide. Since the pulmonary veins mix their blood with the bronchial veins, by the time the oxygen-rich blood gets back to the heart, the partial pressure of oxygen drops to about 95 millimeters of mercury. That leads us to systemic gas exchange. Since the cells use up oxygen and produce carbon dioxide, the interstitial fluid surrounding the systemic capillaries has a partial pressure of oxygen of 40 millimeters of mercury and a partial pressure of carbon dioxide at 46 millimeters of mercury. As the gases move down their partial pressure gradients, oxygen is unloaded from the blood and diffuses into the interstitial fluid while carbon dioxide is loaded into the blood from the interstitial fluid. As a result, the blood that enters the systemic venules from the capillaries has a partial pressure of oxygen of 40 millimeters of mercury and a partial pressure of carbon dioxide of 46 millimeters of mercury, which matches that of the interstitial fluid. And now that is our oxygen-poor blood again. And it's going to travel back up to the right side of the heart and is going to be pumped into the lungs so they can start the whole process over again. Reloading oxygen, getting rid of the CO2. And then we exhale that air back out of our alveoli and inhale fresh atmospheric air right back in. That's the basics of gas exchange. It's really not that complicated. One thing you'll likely see in class is the oxyhemoglobin dissociation curve, which is a graph that shows how different conditions influence when hemoglobin in red blood cells binds to oxygen and when it releases it. Understanding this curve is important for comprehending how oxygen is transported through the bloodstream and delivered to tissues. I will post an image of this curve on Instagram so you can see what I'm talking about. But let's talk about this curve. So what does the curve represent? Well, on the x-axis, we have the partial pressure of oxygen, or PO2. This represents how much oxygen is available in the blood, measured in millimeters of mercury. On the y-axis, we have the percentage of hemoglobin saturation with oxygen, meaning how much oxygen is bound to hemoglobin, ranging from 0%, which means no oxygen, to 100%, which means full saturation. The curve has a sigmoidal or S shape. That means it's not a straight line. Remembering that one molecule of hemoglobin can bind to 4 molecules of oxygen, this shape reflects the cooperative nature of oxygen binding to hemoglobin. Here's why. When the first oxygen molecule binds to hemoglobin, the hemoglobin undergoes a slight conformational change that makes it easier for the second oxygen molecule to bind. As more oxygen binds, hemoglobin becomes progressively easier to bind with additional oxygen molecules until it's fully saturated. So the curve gets steeper after the first oxygen molecule binds to hemoglobin. So here are some of the key points on the curve. At low PO2, which is what we see at the interstitial fluid, hemoglobin has a lower affinity for oxygen, meaning it will release oxygen to the tissues more easily. This makes it better for delivering oxygen to our tissues. At high PO2, like in the alveoli where oxygen is abundant, hemoglobin has a high affinity for oxygen, so it picks up more oxygen more efficiently. This is good for reoxygenating blood in the lungs. You'll notice that when the conditions change, the curve shifts left or right. The position of the oxyhemoglobin dissociation curve can shift to the left or right depending on several factors which affect hemoglobin's affinity for oxygen. If it shifts to the right, that means hemoglobin has decreased affinity for oxygen, or another way to say it is more likely to release oxygen. These are conditions we see in active tissues. These are the tissues that are using up their oxygen, so they need the blood to deliver more. This happens when there's increased carbon dioxide, which lowers the hemoglobin's affinity for oxygen, promoting oxygen release, increased temperature, so as tissues get more active, they produce more heat. So now we will make a situation where oxygen will be released more readily. A decreased pH, which means more acidity. The blood becomes more acidic due to lactic acid buildup from these active tissues. And an increased 2,3-DPG. This is a molecule that is produced during anaerobic fermentation and also helps reduce hemoglobin's oxygen affinity. All of those create a shift to the right, meaning that the blood will be more readily available to release oxygen. A shift to the left means hemoglobin has an increased affinity for oxygen, meaning it is more likely to bind oxygen. These are basically the opposite of tissue conditions and are mostly found in the lungs where we want to get oxygen into the blood. So a decreased carbon dioxide, a lower temperature, higher pH, and decreased 2,3-DPG all cause hemoglobin to hold on to oxygen more tightly and to bind more oxygen, which is useful when oxygen needs to be stored, like in the lungs.
Bombas makes the most comfortable socks, underwear, and T-shirts.
Warning, Bombas are so absurdly comfortable you may throw out all your other clothes.
Sorry, do we legally have to say that?
No, this is just how I talk, and I really love my Bombas.
They do feel that good. And they do good, too. One item purchased equals one item donated.
To feel good and do good, go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
So why is this clinically significant for us? Understanding the dissociation curve helps explain how oxygen delivery changes under different physiological conditions. For instance, in high altitudes, where oxygen levels are lower, the body adjusts by shifting the curve to the right, which helps release oxygen more readily to tissues. Also to the right would be conditions like sepsis or exercise, which increase carbon dioxide or temperature that will also ensure that oxygen is delivered to metabolically active tissues. This curve is crucial for understanding how hemoglobin binds and releases oxygen. It shows that hemoglobin's affinity for oxygen is influenced by factors like partial pressure of oxygen, pH, carbon dioxide, temperature, and 2,3 dPg. The curve shifts right or left depending on these factors, which helps optimize oxygen delivery based on the body's needs. So you should take a good look at that curve. You're likely going to cover it in class. I would be shocked if it's not on one of your exams. So hopefully this helps you understand it a little better. Finally, let's talk about the lungs' role in helping control the acidity of the blood. This is really important because a pH below 7.35 is considered acidosis, and acids denature proteins. These proteins are the building blocks of our tissues, enzymes, hormones, neurotransmitters, receptors, you name it. So let's look at the way the lungs help to control pH levels in our bodies. We transport carbon dioxide through our blood in 3 different forms: carbonic acid, carbamino compounds, which are molecules of hemoglobin with carbon dioxide bound to them, or as a gas directly dissolved in the blood's plasma. So we can have carbon dioxide just in the blood's plasma, we can have carbon dioxide bound to hemoglobin, or we can convert carbon dioxide to carbonic acid. The vast majority is carbonic acid. So that's what we're going to focus on. In the blood, about 70% of the carbon dioxide reacts with water in what's called a hydration reaction. This is catalyzed by an enzyme called carbonic anhydrase, and the result is the compound called carbonic acid, which then dissociates into bicarbonate and hydrogen ions, which is what acids do when they're in water. So basically, it's CO2 plus H2O yields carbonic acid, H2CO3, which then dissociates into HCO3 minus, which is a bicarbonate ion, and a hydrogen ion. Those hydrogen ions are the reason why the blood's pH decreases when CO2 levels rise. Remember, a lower pH means more acidity. In our plasma membrane, we have an antiport called the chloride bicarbonate exchanger, which pumps most of the bicarbonate ions out of the red blood cell in exchange for chloride ions from the blood's plasma. And we call that exchange the chloride shift. Most of the hydrogen ions, however, remain inside the red blood cell and bind to hemoglobin or oxyhemoglobin, which is hemoglobin that already has oxygen bound to it. This action buffers the hydrogen ions, keeping the inside of the red blood cell from getting too acidic. So what does that mean? Since active tissues produce more carbon dioxide, the tissue fluid and in turn the capillary blood gets more acidic. Under normal circumstances, this is totally fine because the acidity causes hemoglobin to release its oxygen to the tissue fluid, which is great. That's what we need. When that blood gets to the pulmonary capillaries, these reactions reverse themselves, allowing carbon dioxide to be released into the alveolar air and oxygen to be loaded onto the hemoglobin of the red blood cell. This is great because we can use our lungs to expire all that carbon dioxide and keep our pH at a normal level, and we're putting the oxygen back into the blood so that when it gets back to our systemic tissues, we can give those tissues the oxygen it needs. And also, since we blew off all that carbon dioxide, we'll have room to get the carbon dioxide from the tissues so they don't get too acidic. All right, I think that's good for the respiratory system for the podcast. With these couple of episodes, I think you got a lot of what you'll probably need for most exams in a 2-semester A&P course. So I hope that that is all working out for you. I hope that this podcast is helping you get your B or better. I want to give a big thank you to my sister, Christina Byrne, dental hygienist outside of Chicago in the USA. We got a lot of really good information about being a dental hygienist, what it takes to become one, what you can do as a dental hygienist. That was really good, and I super appreciate her coming on and giving us all that great information. Thank you so much for listening. I really appreciate it. It would be a huge help if you reviewed and rated the podcast on whatever platform you're using. Please recommend to your friends, your professors. Let's get this out to as many people as we possibly can. That would be fantastic, and I would really appreciate that. And don't forget, you can email me at minus55media@gmail.com. Ask me a question. Maybe I'll answer it on a subsequent episode. That's always a lot of fun. I've been getting a lot of great emails. I got one recently from someone who is in the UK studying nursing. They said the podcast is really, really helping them out. That makes it all worth it. Don't forget, I've got an Instagram account that I am starting to put some videos on that might be helpful with your A&P study. So check me out on Instagram at StudentHelp4AP. That's the number 4, AP. And you can also find lots of tutor videos on YouTube. StudentHelp4AP. That is my YouTube channel. The links are in the show notes, in the profile. You can find all of it. Once again, thank you so much, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media. Please take the time to rate the podcast, and don't forget to check out my YouTube channel, Student Help for AP. That's Student Help, the number 4, AP. There's a whole lot of tutor videos on there that I think you're going to find helpful. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where you can find Anatomy and Physiology Digital Suite, my low-cost, tutor video-based digital learning solution for anatomy and physiology, already being used at several colleges and universities.